What 3 considerations are necessary before adrenal gland biopsy? When a mass is found on your adrenal gland, should a biopsy be performed? The answer is not always straightforward, and making the wrong decision can have serious consequences. In this video, we will explore the 3 critical criteria that must be met before an adrenal biopsy should even be considered, when this procedure is appropriate, and importantly, when it should be avoided through evidence-based content curated by Saboor, fellowship-trained consultant surgeon. To understand when adrenal biopsy is necessary, we first need to establish what we are dealing with. An adrenal biopsy is a procedure where a small tissue sample is taken from an adrenal gland mass. The adrenal glands are small hormone-producing organs that sit on top of each kidney. This procedure is typically performed by interventional radiologists, physicians specially trained in using imaging guidance to perform minimally invasive procedures. Most adrenal masses discovered incidentally on imaging scans are benign adenomas, non-cancerous growths that often require no treatment. However, some masses may be adrenocortical carcinoma, a rare but aggressive adrenal cancer, Pheochromocytoma, a hormone-secreting tumor that can cause dangerous blood pressure spikes, or metastases, cancers that have spread from elsewhere in the body. Before we dive deeper, let us establish what we are dealing with and why this matters to you personally. The decision to biopsy or not affects your treatment path, surgical planning, and ultimately, your outcomes. Number 1. Pheochromocytoma must be biochemically excluded. This criterion exists because biopsying a pheochromocytoma can trigger a life-threatening catecholamine crisis, a sudden massive release of stress hormones that can cause fatal blood pressure spikes, heart rhythm abnormalities, and stroke. International guidelines recommend measurement of plasma-free metanephrines, or urinary fractionated metanephrines, biochemical markers that detect hormone production from these tumors. It is almost impossible to distinguish a pheochromocytoma from other adrenal masses, including metastases, using conventional imaging alone. Even when an adrenal mass in a patient with known cancer appears likely to be a metastasis, pheochromocytoma testing is still mandatory before any biopsy is considered. The risk is simply too high to proceed without biochemical confirmation. This is non-negotiable safety protocol that protects you from potentially catastrophic complications. Number 2. Imaging features must not be characteristic of benign adenoma. Adrenal biopsy is only recommended when a mass has not been conclusively characterized as benign by imaging studies. On computed tomography scanning, benign adenomas typically show unenhanced attenuation values, less than or equal to 10 Hounsfield units, a measurement of tissue density. If your adrenal lesion meets these benign imaging criteria, no biopsy is needed, because imaging has already provided the answer. The procedure carries a non-diagnostic rate, meaning it fails to provide useful tissue in approximately 9 out of every 100 biopsies performed. When you consider that imaging can often definitively characterize benign lesions, subjecting patients to an invasive procedure with a nearly 1 in 10 failure rate makes little sense when imaging has already provided clarity. Adrenal biopsy has significantly lower diagnostic performance for adrenocortical carcinoma specifically, with sensitivity dropping to 70%. This means that in 30 out of 100 cases where adrenocortical carcinoma is actually present, the biopsy may miss the diagnosis. But here is where it gets concerning. Biopsying a suspected adrenocortical carcinoma carries the serious risk of tumor dissemination, spreading cancer cells along the needle track or into surrounding tissues. This can preclude an R0 resection, complete surgical removal with clear margins, which is the only curative treatment option. Research has demonstrated that adrenal biopsy in patients with early-stage adrenocortical carcinoma is associated with decreased overall survival. The only exceptions might be when formal tissue confirmation is needed, in an inoperable tumor to guide chemotherapy decisions, or as part of a clinical research trial. Number 3. The biopsy result must impact clinical management. This is perhaps the most important criterion because it addresses the fundamental question: will knowing the biopsy result change what we do for the patient? If clinical management would not be altered regardless of the biopsy findings, then the procedure exposes you to risk without potential benefit. In patients with advanced extraadrenal malignancy, cancer that originated outside the adrenal glands, who already have multiple metastases throughout the body, knowing whether the adrenal mass is also a metastasis typically does not change treatment. However, if a patient has no other obvious metastatic lesions and surgical removal of a solitary adrenal metastasis is potentially reasonable from an oncological standpoint, then confirming the nature of that lesion through biopsy could meaningfully alter the treatment plan. The procedure has an overall complication rate of approximately 2 to 3%. Think of this in context. If 100 people undergo adrenal biopsy, 2 to 3 will experience complications, which can include bleeding, infection, or pneumothorax, collapsed lung. So here is your bottom line. Let us talk about the 3 categories of action that apply, whether you are a patient facing this decision or a healthcare provider evaluating an adrenal mass. This week, if you or someone you care about has been told an adrenal mass was found on imaging, Ensure that hormonal testing has been completed before any biopsy is discussed. Specifically, ask whether plasma-free metanephrines or 24-hour urinary fractionated metanephrines have been measured to exclude pheochromocytoma. Review your imaging report and ask your physician about the Hounsfield unit measurement on non-contrast cord. If this value is 10 or below, the mass is likely benign and biopsy may not be necessary. If you have a history of cancer elsewhere in your body, ask your oncology team whether knowing the nature of the adrenal mass would actually change your treatment plan. Do not assume a biopsy is automatically indicated just because a mass was found. Discuss with your doctor. Come prepared with these specific questions. First, have all three criteria for adrenal biopsy been met in my case? Is pheochromocytoma excluded? Is the mass indeterminate on imaging? And will the result change my treatment? Second, if adrenocortical carcinoma is suspected, why is biopsy being considered given the risk of tumor spread and decreased survival? Third, what is the experience level of the interventional radiologist who would perform the procedure? And what is your institution's non-diagnostic rate and complication rate for adrenal biopsies? Fourth, if I have known cancer elsewhere, could FDG PET-CT scanning, positron emission tomography that detects metabolically active cancer cells, or surgical resection be better alternatives to biopsy? If you are supporting someone through this decision-making process, accompany them to appointments and help ensure these questions are answered clearly. When to seek help? Certain situations demand urgent multidisciplinary team discussion, a meeting of specialists from endocrinology, radiology, surgery, oncology, and pathology who collectively determine the best approach. Request this if your adrenal mass is 4 centimeters or larger and shows heterogeneous appearance, irregular, mixed tissue characteristics, on imaging. Seek immediate expert consultation if surgery or biopsy is being recommended without documented biochemical exclusion of pheochromocytoma. If you are younger than 40 years of age with an indeterminate adrenal mass, urgent assessment is warranted because malignancy likelihood is higher in younger patients. If you have known extra-adrenal malignancy and your adrenal mass cannot be characterized on routine imaging, ensure evaluation includes discussion of whether FDG PET-CT, biopsy, or surgical resection is most appropriate based on whether the result will change your oncological management. Let me quickly recap. Adrenal biopsy is only appropriate when 3 specific criteria are met. Pheochromocytoma is biochemically excluded, imaging has not characterized the mass as benign, and knowing the histology will alter your treatment plan. Your next step is ensuring all 3 criteria are documented before any biopsy proceeds. This information is for education. Always discuss your individual situation with your healthcare provider. The European Society of Endocrinology Clinical Practice Guidelines on Adrenal Incidentalomas provide comprehensive, evidence-based recommendations for when adrenal biopsy is appropriate, emphasizing the critical importance of excluding pheochromocytoma and ensuring the procedure will impact management decisions. These international guidelines are developed by multidisciplinary expert panels and represent the current standard of care for adrenal mass evaluation.